Thanks again for the invitation to this Congress, and I'm very happy to present biliary interventions because they are one of my favorites. The talk is not limited to liver transplantation only, but the general principles in treatment are also all the same. So this is my agenda. First, a few general aspects. If we talk about percutaneous biliary interventions, there is, in the start, you always have to hit the duct and inject contrast in the biliary system. So this is called the percutaneous transhepatic cholangiography. But in radiology, we do not use it as diagnostic anymore. Because it's an invasive procedure and you always have the risk of bleeding. The alternative is an MRI with liver-specific contrast agents to visualize the biliary ducts and also leakages. But the PTC is always the first step in a biliary intervention. And after successfully contrast injection, you have to cannulate the biliary ducts and can start with your intervention. The most common is the PTBD, percutaneous transhepatic biliary drainage, but you can also use balloons and stents. So why do we need to go percutaneously? In the previous talk, we saw all the endoscopic options and it's the standard approach, but sometimes you cannot reach the biliary system, especially in bilioenteric anastomosis or other kind of stenosis for the endoscopic approach. In percutaneous approaches, there are two different settings for the interventionalist. The easier one is with dilated bile ducts in cholestasis if you have a stricture after transplantation, but there are many reasons why you can have cholestasis. But for an interventionalist, it's much more difficult if we are treating leakages, because then we have to deal with non-dilated ducts, and this increases the complexity of the intervention a lot. How does it look like in the interventional suite? We prepare the patient like that. If we want to go to the right liver, we try to go subcostal or intercostal way. And for the left liver, it's right below the sternum. Most of the interventions will be done in analgosedation and not in general anesthesia. This is how it looks like, but biliary interventions percutaneously are very basic from the materials. You just need a thin needle and you have to hit the duct. That's the main, that's your main task. And here is a video where you can see how tiny these ducts can be. And performing a successful cholangiography is always the first step. If you manage this, you have to cannulate the duct to insert a drain or a stent, and for this reason you always need a very thin wire, a microguide wire, to cannulate the biliary system. And in this case you can see it's a leakage at the anastomotic site, bilioenteric anastomosis. After successful cannulation, you insert the drain, and then probably the insufficiency can heal. What are the problems percutaneously? If you do a left-sided approach, it's not that comfortable for the radiologist. You can see these are my hands, and it's not that easy to do it with good radiation protection. If we're talking about biliary drainages percutaneously, there is always the debate what kind of drain to insert. And generally spoken, there are three types that we are using external drainage, internal external drainage, and a special kind of internal external drainage, the so-called Yamakawa or Müller drainage. What is the difference? The external drainage, there the drain lies with the holes inside of the liver most of the time, and the bile can only flow through the drain outside of the body. But this is not good for longer term drainage. So you always have the goal to internalize such a drain and exchange it for an internal external drainage. And the difference is that there are holes over the whole biliary system and in the duodenum or in the bilioenteric anastomosis. Because if you close the drainage outside, it works as a stent. And if you plan to do a longer term drainage, then you should use the Yamakawa drain because it's very soft and it can stay in for months. If we're talking about stents, you can also use plastic and metal stents percutaneously. Metal stents, you can also use fully covered stents to treat leakages. And now I want to show you some standard cases. Most of the times we have an MRI available for planning the procedure. In this case, it's a case with dilated ducts because of a tumor compression in a recurrence of a cholangiocarcinoma. If you look at this MRCP, you can see that there are a lot of stenosis, and should you treat that with drainage, you always have to look for connected system like this in the posterolateral pedicle, and it should always be your goal to decompress about 50% of the biliary tree to have a clinical effect. So it was a dilated duct system, and I thought, what a nice case, easy puncture. And I show you here, cholangiography really went smoothly, but in this video, I will show you that you have to stay focused because the cannulation can be exhausting, I would say. You see, you have to move on and don't give up. And in the end, I made it. So after the cannulation, you can insert a drainage. In this case, there was no drainage of the contrast to the bilioenteric anastomosis, so we decided to put in an external drainage first. And the standard approach is to internalize this drainage after approximately 3 days. In this case, I used a cone beam CT to do a 3D cholangiography where we can see the stenosis very good, and I managed to cannulate it and insert a so-called Yamakawa drain. Here we have a case of anastomotic stenosis after liver transplant, bilioenteric anastomosis. You can see there's almost no drainage through the anastomosis. And first we drained it. I managed to cannulate through the anastomosis, and afterwards you always try to upsize the drainage to treat the stenosis, and we also use balloon catheters after healing of the anastomosis, of course. And in this case, you can see that now with a bigger drain, the bile is flowing through, and this patient got his drain removed after 3 months, I think. Then there's the other way, stenting. In this case, we have a leakage of the common bile duct caused by a pancreatitis case, and you can easily see this big leakage. We put a Yamakawa drain inside for quite a long time, but it didn't heal, so we decided to put in a fully covered stent percutaneously in this case, because the endoscopist could not come into the bile duct that easily because of the inflammation And after covering the leakage site with the stent, the leakage was no longer visible. So I want to show you some other tips and tricks, what you can perform percutaneously and what you can expect from your interventional radiologist. This was a case with a bilioma after a non-anatomical resection. A drainage is inside, and because the first step is always the contrast injection in the bile ducts, sometimes you can use alternative methods to contrast these bile ducts, not by puncturing it. You can inject contrast via the drainage and then puncture the ducts easily. You can see the limited steerability of those thin needles, but if you access, then you can insert your drain and everything is fine. There is one more very challenging case for me, because this patient had a duodenal stump insufficiency after bariatric surgery, and the problem was her BMI was about 59, so that's really challenging for percutaneous approach, and I did not manage to create a cholangiography, so I decided to puncture the gallbladder because it was left inside to indirectly visualize the bile ducts, and it worked quite well, but even with the visible bile ducts, it was not that easy to cannulate. I needed a few attempts from the right and left side, and then again the right side, and after that I could put in the drain to heal the duodenal stump insufficiency. It looks like that because the patient was so big, the drain was at its limit. Then we also have to deal with biliary leakages after trauma. This was a young woman who had a car accident at her birthday, unfortunately, and had this liver laceration. Endoscopically, you can see the bile leak inside the laceration, and they put in some plastic stents, but it did not heal, so we decided to percutaneously drain the bilioma with a CT-guided drainage, and it did not heal that well with only the plastic stents, so we decided to put in percutaneous drain, and there you can see what kind of tricks you can use, because the stents are very helpful to puncture the biliary ducts, and with this kind of trick it's not that hard when the ducts are not dilated. So we put in drainage, and the special thing about this case is that there is a hole in the biliary system in the middle. So what kind of drainage should you put in? So we decided to measure the distance to the leakage and made an individualized drainage for the patient, that there are no holes in the part of the leakage, and so the bile leak could heal very nicely in this case. So another case of liver transplantation, it was an ischemic type stenosis. You can not see the hilum, so it's a very advanced stenosis, and if you go inside of these ducts, you don't see the left, in this case, main duct, which was not reachable by endoscopy. And in these cases, you sometimes have to do a sharp recanalization. It means that you do not cannulate it with the normal wire. You have to use the stiff end of the wire and puncture. And if you have a good planning, like in these 3D pictures, you can reach the main duct again and reconnect the system with the drainage. Here This is the last case I wanted to show you. You see a very big bilioma after cholecystectomy. And what happened? So we inserted a percutaneous drainage, and an ERCP was performed after we knew that it's bile. And you can see that there's a large defect in the right main duct, and the endoscopist could not cross the leaking side, so he put in a stent to the left, what doesn't make sense to me at all, but he did it. So we tried to go into the right duct percutaneously, but unfortunately our wire always went into the bilioma. So as we've seen before, sometimes there is a rendezvous maneuver from endoscopy and radiology percutaneously. So we put in the wire inside of the bilioma, and then the endoscopist comes and also goes into the bilioma with another wire so that it can be fetched with a snare, and then we have a pull-through wire and can insert a stent, or in this case, a drainage. These are the images after the rendezvous procedure. So I'm already out of time, but only a few slides left of a very recent article from our group to treat isolated bile leakages. You sometimes have the problem after non-anatomical resections that there is leaking, bile leaking into the defect, but the biliary duct which is leaking is no longer connected to the biliary tree. So you cannot treat it with endoscopic drainage or with a PTBD. Most of these cases really need a long-term bilioma drainage, and we thought about manage it with thermal ablation according to surgical closing of the duct with heat. So we performed microwave ablation at the leaking duct in 12 patients, and we had very good results in cessation of these leaks by thermal ablation of isolated bile leaks. So I'm finished with the talk, and thank you for listening.